Thank you, Dr. Nabila, for the nice introduction. And I would like to thank, in the beginning, also the organizing committee and the scientific committee, and of course, Johnson, which gave me the opportunity to participate in this wonderful conference. So my presentation is with title, Start Strong, Go Long. So as dermatologists, what we need to start with strong biological medication to maintain the efficacy of the medication for a long period of time. This is the objectives that I'm going to cover in my presentation: the importance of IL-23 in the pathophysiology of psoriatic disease management. Tremfya at the earliest change the course of the disease, so using Tremfya, treating our patient in the early stage will give better results versus late treatment. Tremfya also superiority and sustainability data versus other biological treatment. Tremfya role in patients with genital psoriasis, also to see the difference between the IL-23 inhibitors, Tremfya role in the management of psoriatic arthritis, and also the safety profile of Tremfya, and in the end will be the real-world evidence. So as you see here in my first slide of my presentation, the waterfall, I think most of you are familiar with this picture. It shows the overview of the biological medications when we are talking about the different, when it comes to the mechanism of action of the biological medications. As you see here, we have the Tremfya. The pointer is moving a bit weird. Okay, anyway, so if you see upstream, the Tremfya is working upstream as upregulatory cytokine inhibitor of biological treatment versus IL-17, which is working downstream. So Tremfya upstream inhibits the communication between innate and adaptive immune system, which means that we work before we interfere with the adaptive system by blocking the IL-23. So upstream, when we block the IL-23, the source of the production of IL-23, that will fight the inflammation and block the inflammatory cascade for the disease. While IL-17, they block or inhibit the end results of the inflammatory cascade. That's why we see some risk of the inflammation, and also there will be some of the communication between innate and adaptive immune system. So what are the benefits working upstream or downstream? The benefits upstream, you will see with the Tremfya, it has a small induction, longer intervals of administration, no rebound, which is very important to have no risk or low risk of loss of efficacy, long remission, disease course modification. What about the downstream benefits? Yes, IL-17 has more frequent doses, quick onset of action, but at the same time, it has a quick relapse and potential for rebound and loss of efficacy. Okay, here we have the WHO Global Report on Psoriasis, looking for the patient needs and psoriasis treatment. So every psoriasis patient come to your visit, of course, we will focus on concern about patient needs. So here we see patient is looking for getting better skin quickly, with fast action of the biological treatment, recover from all skin lesions to have better quality of life, and also to get rid of the fear for patients when we are thinking after the healing of the disease or improvement of the disease, there will be a fear of relapse of the disease with the time. Moving now to the one of the best clinical trial called GUIDE, done by Johnson to study the role of T resident memory cell and the T regulatory in the recurrence of psoriasis. So we have other inflammatory cell, which is important in psoriasis. It's responsible for the relapse and recurrence of psoriasis. That's why, even with the chronicity, if patient has a chronic disease, long disease duration, they will have more memory cells. That's why patient may get or has risk to get the recurrence of lesions at the same site of the old lesions. So it's very important to know even the benefits between short disease duration and long disease duration. So with the long disease duration, we have more and more level of memory cells. That's why there is high risk of recurrence of the disease. Okay, here is the design for the guide clinical trial. The goal of this design of this trial is to study the efficacy of Tremfya in two groups, actually, the short disease duration group and the long disease duration group. This study has three parts. In part 1, they treated the patient with gozerkumab 100 milligram at week 0, then 4, then every 8 weeks. So what happened then? At week 20, they took those patients who achieved clear skin PASI 0, which called super responder, and joined them or moved them to the part 2. So what they did in part 2 in this study, they randomized the group into two groups. The group continued on 100 milligram every 8 weeks, and the other group continued on 100 milligram, but every 16 weeks. So they want to see what will happen if we have different intervals every 8 weeks and every 6 weeks. Are they going to maintain the efficacy of the medication equally? There will be non-inferiority that we'll see also with the results. But part 3 will talk about the clinical data regarding the withdrawal of the medication. This is very interesting when we are talking about the T resident memory cells. If you can see here, we have non-lesional and lesional. At the level of the non-lesional, we will see normal level of memory cells, while in lesional, we'll see high level of memory cells. After initiating and treating the patient with the Tremfya, you see the reduction of the level of the memory cells as early as week 4. And we're about 28, it's more reduction also at week 28. And it becomes almost normal at week 68 as what we see in non-lesional tissue. This is what we have discussed in the part 2 of the study. They have divided the super responders patient into two groups, 100 milligram every 8 weeks, and the other group every 16 weeks. So let us see also the result. Okay, here we can see about 92% of patients with gozerkumab every 8 weeks achieved a clear skin by achieving PASI less than 3, while the group every 16 weeks was 91%. So almost there is no difference. So there is no inferiority of the intervals when we are working on 8 weeks or every 16 weeks. And you can see also here, after week 28, both groups, the one continued on 16 or 8 weeks, are almost the same and maintain the efficacy of Tremfya till week 68. This is very interesting when we are talking about the duration of the disease. Here we have short disease duration and long disease duration. If we initiate the treatment, if we treat the patient early, that will help to normalize or decrease the level of the memory cells as early as you see here, week 4. While those patients with long disease duration, with more level of memory cells, they will take time to be normalized or to go to the normal level of memory cells, as you see here, till week 68. So it is better, as message here to all of us, treat patient early as short the duration of the disease to get better efficacy because of the low level of memory cells. Okay, what about the withdrawal of medication as part of the clinical trial? So here, after the withdrawal of the medication, the super responders patient maintained the efficacy of Tremfya over, as you see here, 301 days. But what about if we're talking deeper about the two groups, the long disease duration and the short disease duration? As you see, the short disease duration maintained the efficacy over a long period, 398 days versus 233 days for those patients with long disease duration. Okay, here it's very interesting. There are also another type of inflammatory cells or autoinflammatory cell that's identified also to support the patient to be one of the super responder. This cell is called IL-10 plus T cell levels. So also they are different in the long disease duration and the short disease duration. In the short disease duration, they have up to 4.6 times higher IL-10 plus T cell levels compared with the long disease duration, which are much less. So it's very important to have such cells to fight the inflammation and get better results with the medication. So here, Tremfya has deep and durable response. It plays a big role in reducing the T resident memory cells. Early treatment, as I mentioned, will lead to faster normalization of the memory cells versus late treatment. Super responders show greater skin clearance and faster normalization of the memory cells versus normal responders. And regarding the IL-10 plus T cell counts, the higher level is a potential biomarker to predict the super response. Regarding the clinical practice, as you see here, that's what you see in your clinic. Patient with widespread psoriasis on the body, of course, they have bad quality of life. That, of course, will have negative impact on quality of life of the patient. So as you see in this picture, the PASI is very high. It's 40.5, and affect the quality of life, which showed here the DLQI is 17. After initiating the treatment, as you see here, at week 20, patient had got great reduction in PASI, great improvement of the skin. PASI now is 5.4, and the DLQI is 0. So further reduction with more improvement of the skin, as you see also at week 32. This is very important. When we are talking about Tremfya or any medication, we usually ask for any head-to-head study to compare with the medication if it is new. So here we have different clinical trials studied head-to-head Tremfya with other biological treatments. We have a large head-to-head study with adalimumab. As you can see here, at week 48, 81% or almost 80% of patients achieved PASI 90, and also here PASI 100 versus the adalimumab. It was only 37 achieved PASI 90 and 23 in achieving PASI 100. What about the ustekinumab? They have two clinical trials. We have Navigate and Compass. As you see here, over 1 year, 51%, so more than 50% of the patient achieved also PASI 90 over 1 year, and here also it's about 74% of the patient achieved PASI 90 compared with ustekinumab. When it comes to IL-17 inhibitors, it's very important. Usually when we're talking about IL-23, we want to know if there are also head-to-head study with IL-17. So we have here Eclipse head-to-head study with secukinumab. You see here also at week 48, 84% of patients on Tremfya achieved PASI 90 versus 70% of those patients on secukinumab. Here also we see 58% of patients on Tremfya achieve PASI 100 versus 48% those on secukinumab. So in a period of time also you can notice that there is loss of efficacy of secukinumab with the time. What about the match adjunctive indirect comparison? There is also a head-to-head study with ixekizumab, studied the long-term efficacy of Tremfya over 2 years. So here also it shows great results of long-term efficacy of Tremfya. So at year 2, you can see the superiority of Tremfya versus ixekizumab. Here also we have a complementary data talking about Tremfya that had highest rate of drug survival with great efficacy compared with the other medications. Okay, here also back to our message. Start strong, go long. So again, we need strong biological treatment to maintain the efficacy of the medication for a long period of time. Here we have clinical data for 5 years, excellent clinical data for Tremfya. As you see here, after 5 years, 84% of the patient maintained PASI 90, and also 53% of the patient maintained PASI 100. Okay, now we're moving to some clinical trials done on the efficacy of Tremfya in treating genital psoriasis. We have two studies, one German study called the GE-POST study and the Italian study called the Gulliver study. They involve many number of patients, as you see here, 200 and 300, 300 and 400 from many also medical centers. So this is Gulliver. It's prospective real-world cohort study. It shows the great efficacy of Tremfya as early as week 12, and also there is also excellent data regarding the efficacy of Tremfya at week 28 that presented also in EADV last year, but the data in 52 not presented yet. So let us see here at as early at week 12, we see 87% of the patient achieved clear or almost clear skin with achieving PGA 0/1 at week 12, and also those with genital psoriasis, 76% of the patient achieved clear or almost clear skin. Okay, here again we have the German study, the GE-POST, also showing that treating genital psoriasis will improve the quality of life of the patient and help the patient feel less stigmatized. So we can see here, for those patients with genital psoriasis, more than 3 times more patients feel more positive about intimacy with the partner at week 28. What about the facial psoriasis? Also here we have more than 8 times more patients feel more positive about the way others see them at week 28. Okay, again here, as early as week 12, we see a great efficacy of Tremfya in treating anogenital psoriasis, about 45% at week 12, and also it is higher, 57% at week 20, and it is more than 60% of patients also achieved clear skin PGE 0 at week 28, which is the highest percentage we receive regarding the anogenital psoriasis. What about the social difficulties? Of course, patients with genital psoriasis face social difficulties, either men or women. Here it shows that even at baseline, 31% of men experience social difficulties, but after initiating the treatment, at week 24, they got a great reduction till 1.5% of patients suffering from social difficulties. What about the woman? It is more, 42% at baseline having social difficulties, and it reduced to 3.8 after having great, good, strong medication like Tremfya and showed the great result at week 24. So Tremfya can achieve complete, complete skin clearance. It improves the quality of life of the patient, and of course, it reducing the sexual difficulties and the social difficulties, and also improve feelings of stigmatization. And now moving to the differences between IL-23. It's very important and interesting part I'm going to show you in the coming couples of slides. So, do you know the differences between IL-23 inhibitors? So here we can see Guselkumab is a fully human antibody, while risankizumab is humanized antibody. What does it mean? If you think about anti-drug antibodies, if we have higher level of anti-drug antibodies, it means that we have high immunogenicity that will affect the sustainability of the disease and treatment persistence. Here we see risankizumab has 24% of anti-drug antibodies versus Guselkumab, which is very low, less than 6%. That means that we have great efficacy, we can maintain the efficacy of the disease, and also patient also capture the efficacy even with the retreatment. Going to show you some data regarding the retreatment. And here we can see the retreatment data. 94% of patients on Guselkumab achieved PASI 90 after retreatment with Guselkumab, while with the risankizumab, it is 84% of patients achieved PGA 0/1. Here is very interesting. I can show you here if we think about the molecule itself. Here we have the gozalcumab molecule, and here we have risankizumab molecule.
1 minute, I'll give you.
Okay. So here, if you can see, the gozalcumab binds to the IL-23 that's circulating in the bloodstream, and also it binds to the receptor on inflammatory monocytes. So the gozalcumab molecule combines to both the circulating IL-23 and also the source of production of IL-23 on inflammatory monocytes. While risankizumab, you can see there is a mutation in this part, the FC region. That's why risankizumab can bind only with the circulating IL-23, but cannot bind with the source of production of IL-23. This is what is unique with the gozalcumab in blocking or inhibiting the production of IL-23. We can move here, it's almost the same. This is the last part about the real-world evidence. When we're talking about gozalcumab, we have more than 250,000 patient years exposed. We have more than 21,000 patients treated in real-world registries. We have 52 patient registries and 40 published full-length peer-reviewed articles. And those patients had also more than 10 comorbidities, different hard-to-treat areas, and also in different ethnicities. While risankizumab, here you can see low number of patients. It's about 4,800 compared with the gozalcumab was more than 250,000. Here we have 32 patients registered where there was 15 published full-length peer-reviewed articles, and in gozalcumab it was 40. And here regarding the psoriatic arthritis, we know all of these 5 biological treatments are indicated to treat psoriasis and psoriatic arthritis. And all of them have high probability of ACR 50 and PASI 90. But Tremfya offers the highest probability of ACR 50 and PASI 90 through first year. It's very important to know about this. I'm not going talking in details about safety profile of Tremfya, but it's very interesting to know that in the clinical trials, they involved patients who had history of malignancies treated and cured more than 5 years. So they followed those patients under the study. What they found, no concerning patterns were observed with Tremfya in patients with prior malignancies. So no much fear of having patients cured from malignancies for more than 5 years. And here, this is the last slide talking about the convenience of the Tremfya injection. It is subcutaneous injection, 100 milligrams single dose. You can see in the first year, patients require only 8 injections, and with the maintenance dose, it requires only 6 injections. So start strong, go long. That's what we need as dermatologists, to have very effective treatments, safe medication, good durability, low number of memory cells, as you see with my presentation. Thank you.